Welcome to the presentation about platelet-rich plasma. Platelet-rich plasma is used clinically for healing properties attributed to increased concentrations of growth factors in secretory proteins that enhance the healing process on the cellular level. They can also enhance recruitment of other cells to the area. The platelets are small, non-nucleated, found in peripheral blood, meaning that they are not alive. They are formed in bone marrow from precursor cells known as megakaryocytes, and they cannot replicate. They typically have a 5 to 9 day lifespan. The platelets can become activated when they are exposed to damaged blood vessels. They aggregate at the site, forming a clot, and then they can release more than 30 bioactive proteins that initiate or regulate hemostasis and/or tissue healing. A normal platelet count is 150,000 to 350,000 per microliter. For platelet-rich plasma, the concentration can be 1 million platelets per microliter in about 5 mL of plasma. They can be associated with the enhancement of healing. Platelet-rich plasma is considered rich plasma when it contains a 3 to 5-fold increase in growth factor concentration. There are many bioactive molecules that are found in the alpha granules of the platelets. These include growth factors, adhesive proteins, clotting factors, fibrinolytic factors, proteases, and antiproteases, basic proteins, and membrane glycoproteins. Some of the growth factors include TGF-beta, which promotes matrix synthesis, PDGF, which has chemoattraction and cell proliferation, IGF, which is responsible for cell proliferation, maturation, and bone matrix synthesis, FGF, which is responsible for angiogenesis and fibroblast proliferation, EGF, which is responsible for cell proliferation, VEGF, which is known to enhance angiogenesis, and ECGF, which is an endothelial cell proliferation, as well as angiogenic factor. These are some of the different growth factors that are identified in platelet-rich plasma: PDEGF, PDGF, both alpha and beta, TGF beta 1, IGF 1 and 2, and VEGF, ECGF, BFGF, as well as CTGF. So for platelet-derived epidermal growth factor, these growth factors will typically target blood vessel cells, outer skin cells, as well as fibroblasts, and their function is to promote cell growth and recruitment. Also, to promote differentiation, as well as skin closure and cytokine secretion. Platelet-derived growth factor targets fibroblasts, smooth muscle cells, chondrocytes, osteoblasts, and mesenchymal stem cells. They function to help potentiate cell growth and recruitment, increase blood vessel growth and granulation, and they can also act as a growth factor secretion, forming a matrix with bone and protein. Transforming growth factor typically targets blood vessel tissue, outer skin cells, fibroblasts, and monocytes. The TGF gene family may include bone morphogenetic protein, as well as osteoblasts. The function of these growth factors is to help improve blood vessel and collagen synthesis, growth inhibition preventing apoptosis, and differentiation and activation. Insulin-like growth factor targets bone cells, blood vessels, skin, as well as fibroblasts. It functions to help cell growth differentiation, recruitment, and collagen synthesis. Vascular endothelial and endothelial growth factor target blood vessel cells and function to help cell growth, migration, new blood vessel growth, as well as anti-apoptosis or anti-cell death. Basic fibroblast growth factor targets blood vessels, smooth muscle, and skin fibroblasts. It functions to help cell growth and differentiation of chondrocytes, as well as osteoblasts. It's also mitogenic for mesenchymal cells, chondrocytes, and osteoblasts. Connective tissue growth factor is found in platelets through endocytosis from extracellular environment in the bone marrow. It functions to promote angiogenesis, cartilage regeneration, fibrosis, and platelet adhesion. This shows the process of the growth factors released from an activated platelet. There are many surface receptors that exist on the cells, and these will accept those different growth factors, which then create a cascade of events by communicating with the nucleus to make those different events occur, the ones that are specific to each type of growth factor. After they bind to the surface, the receptors will begin with activation and promote that cascade of events within the cell and signal down to the nucleus. That signaling pathway can then be switched on and activate secondary messenger proteins, which can then enter the nucleus to affect the expression of the genes and trigger cell division. This shows the natural process of healing. The first thing that happens is the injury, which is down on the left of this graph, followed by the clot, followed by inflammation, which is when white blood cells will come and begin to destroy everything in the path. And they also will actually mess with the pH balance to create a toxic environment and get rid of anything bad in the area. The body then moves into tissue regeneration, which is where cell proliferation and healing occurs. This is where the stem cells begin to take effect. Finally, tissue remodeling and complete healing. So when you're using platelet-rich plasma, there's a difference between using certain types of platelet-rich plasma, whether you have high white blood cell counts or low. We actually prefer to use a platelet-rich plasma that's actually lower in platelet counts because we can get rid of some of the white blood cells. Once we move into this tissue regeneration point, where we want stem cells to begin proliferating and promote tissue remodeling, we only want our platelets to be activating those stem cells. We do not want the white blood cells to still be creating inflammation. Some of the adhesive proteins that are present in the platelet-rich plasma include fibrinogen, which is responsible for the blood clotting cascade, fibronectin, which binds to the cell surface integrins, affecting cell adhesion, cell growth, migration, and differentiation, vitronectin, which affects cell adhesion and chemotaxis, and thrombospondin, which inhibits angiogenesis. Some of the different clotting factors are factor V, factor 9 and 11, protein S, and antithrombin. These all play a role in thrombin activation and eventual fibrin clot formation. Some of the fibrinolityc factors are plasminogen, which is involved in plasmin production and leads to fibrinolysis, plasminogen activator inhibitor, which is responsible for the regulation of plasmin production, and A2 antiplasmin, which is involved in inactivation of plasmin. A few of the other proteases and antiproteases that are present are TIMP4, which is involved in the regulation of the matrix degradation, metalloprotease 4, which also is responsible for matrix degradation, and antitrypsin, which inhibits a wide variety of proteases and enzymes. There are a few basic proteins that are present, including platelet factor 4, which is involved in the inhibition of angiogenesis, thromboglobulin, which regulates platelet activation and inhibition of angiogenesis, and endostatins, which inhibit the endothelial cell migration in angiogenesis. These are some of the membrane glycoproteins that are present. The CD40 ligand, which is responsible for inflammation and synthesis of the interleukins, integrin production, platelet endothelial cell adhesion, cell signaling, and modulation integrin activation molecule 1 on the leukocytes. Also, P-selectin, which is responsible for vascular cell adhesion molecule aiding in binding and recruitment of leukocytes to the inflamed tissue. These images show the PRP extraction procedure. Blood is collected typically in yellow top tubes, which contain calcium citrate to prevent the clotting. Then the patient's blood is centrifuged to separate the red blood cells from the white blood cells and the platelets. There are different centrifuge methods for obtaining platelet-rich plasma, whether you want to collect high white cell counts, low white cell counts, or no white cell counts. Typically, what we are utilizing in our lab is one 8-minute spin at 500 G, and then collecting all of the yellow portion that exists above the red. If we want only a small volume, we would collect beginning closest to the layer where the red meets the yellow to get the most enriched population. We do not like to collect any of our white cells or red cells to ensure that we have less inflammation when using PRP. The growth factors that are present in the stem cells can actually stimulate stem cells to increase their numbers in proliferation, as well as differentiate into various types of tissue. This demonstrates what happens when you add platelet-rich plasma to mesenchymal cells as they are growing in culture. Some common orthopedic conditions that can be treated with platelet-rich plasma include shoulder disorders such as bursitis and rotator cuff repairs, tendinitis such as tennis elbow, Achilles tendon, and heel spur syndrome, muscle tears, sprains, and trigger points. Also, meniscal tears, mild to moderate degenerative arthritis of various joints, and disorders of the spine. A couple of things. When we're using PRP in the clinic, we will typically only use this in more acute and smaller injuries. If something is very chronic, like osteoarthritis of the joint, we will combine the platelet-rich plasma with the stem cells to deliver that into the joint. We've also heard of several groups doing epidurals of platelet-rich plasma and getting good results in the spine. We also use the platelet-rich plasma with an intradiscal delivery, or combine the cells to do an intradiscal delivery as well for degenerative disc disease. These are some of the different published human clinical studies in orthopedics using platelet-rich plasma. For the most part, we are using platelet-rich plasma only in orthopedics and also in muscle-type injuries. For example, if we're doing something for limb ischemia or wound healing, we would also use the platelet-rich plasma. Whenever we're doing any sort of IV treatment, there's really no reason to use the platelet-rich plasma because you're injecting the stem cells into the blood and there's going to be platelets that are present already. So we do not do a platelet-rich plasma when we're doing IV therapies. To be clear, it's not dangerous. It wouldn't pose a safety concern. It's more that there would be no reason to do an extra step of collecting the platelet-rich plasma. So for an IV treatment, we would only resuspend the cells in saline. However, if we're doing a patient that's going to get an IV plus a joint injection, because we're already obtaining the platelet-rich plasma and we resuspended the cells in that platelet-rich plasma, we would do an IV with the platelet-rich plasma. Again, not necessary. It's not providing any additional promotion. Platelet-rich plasma has also been used quite a bit with hair and hair transplantation. Typically, if we're going to be doing a balding patient, what we would do is the first injection with stem cells plus the platelet-rich plasma, and then follow it with 4 or so injections of platelet-rich plasma every 1 to 2 months. Going throughout the area of the balding and doing subdermal injections just below the surface. There's also been studies showing that PRP can be combined when doing a hair transplantation to help promote healing and growth of that hair after the transplantation by preserving and enhancing the hair follicle viability both during and following hair transplantation, by promoting and enhancing tissue repair and healing, and by reinvigorating the dormant hair follicles and stimulating any new hair growth. For those of you that are interested in using platelet-rich plasma as a facial filler, you can use calcium chloride and thrombin to activate the gel. This would only be done if you're going to be doing it as a facial filler. We do not like to activate our platelets if we're using it in things like a joint, because we feel that the platelets will actually get naturally activated once you place them into a joint, because there's plenty of collagen. Also, an injury will naturally activate those platelets. Once you do activate the platelets, they must be used immediately, so you cannot allow these to sit for very long. In order to create it as a facial filler, this is the formula. Resuspend 5,000 units of thrombin in 6 ml of 10% calcium chloride. You will then take 0.167 ml of that mixture to resuspend each ml of PRP. In other words, if you have 3 ml of PRP, then you would use 3 times 0.167 or 0.5 ml of the thrombin and calcium chloride mixture. Oftentimes you can place this at 37 degrees to make it gel quickly. This concludes the platelet-rich plasma presentation. In the following videos, we will analyze the use of the different stem cells in the clinic.